Hello, I'm Kristy Bird MaKieve. I'm the founder and CEO of Healthy Rural California. I'm also the GME administrator for the GME Committee of Healthy Rural California. I have another hat, which is executive director of Butte-Glenn Medical Society. And all of this adds up to what I'm about to talk about, which is our initiative updates in April of 2022, mostly talking about Healthy Rural California today. It's a challenge to describe graduate medical education and the journey that we've been on for a few years now. So I spent a lot of time thinking about it. And in essence, what we're doing is building a medical school and expanding clinical operations in the region of Northern California. So we're talking about north of Sacramento up to the Oregon border, largely located in Butte County. So graduate medical education and the Health and Technology Education Center are the two largest initiatives that we have with Healthy Rural California. There's some other work that we do in terms of fiscal management for several different coalitions. That's a whole other segment of what we currently do in Healthy Rural California. But today, the big initiatives are really what we want to focus on. Again, we're centered in Butte County, and that is about an hour-and-a-half drive to south to Sacramento. And when I talk about Butte County, it's largely the northern part of Butte County. Our efforts are really to bring more physicians to the community and tackling chronic access to care and health equity issues. In particular, the graduate medical education that we're focused on is a community psychiatry residency and an integrated behavioral health family medicine residency located in and managed by Healthy Rural California in Chico, Butte County. And when I talk about the impact of what that means, in the next few years, in launching a psychiatry and family medicine residency programs, we will be bringing a total of 28 residents who will be continuing their education, but also providing care in the community. That's a pretty big impact. So here are the quick facts. Healthy Rural California is a 501c3 nonprofit organization. And we have a graduate medical education committee that is separate from the Healthy Rural California board. That is because for the graduate medical education committee, we are focused on the academic rigor and strength and also the wellness that we can provide our future residents. And as such, we are now accredited by CGME, which is the Accrediting Council of Graduate Medical Education in the United States. And that sponsoring institution status was awarded to us in the fall of 2021. So it positions us to then build and apply for specialty residency programs. So what is medical education? And I think a lot of us have a just general understanding of what it is. What I wanted to show here is the pipeline. Typically starts as a bachelor degree because you have to have a certain number of requirements. Organic chemistry is probably the most famous and the most challenging during your bachelor's degree. So whether you're a pre-med or related major, that could lead to, if you haven't gotten the requirements, but you have fulfilled the requirements for a bachelor's degree, you might be eligible for or interested in a post-bac program. That is something that's available at UC Davis, for example. Then it's on to medical school. And when we talk about medical school, we're actually talking in terms of medicine as UME, undergraduate medical education. I know that gets a little bit confusing because I think of my bachelor's degree as undergraduate, but in the medical world, UME is decidedly the typical medical school that we talk about. And at the end of that UME journey is an MD or a DO degree. And yet the education must continue. graduate medical education programs are a necessity. They are what lead to board certification. And the residency programs can be another 4 years, maybe longer, maybe less, depending on the specialty that you pursue. And it is education. And so while we tend to think of residents as performing clinical care, which they do, they are actually needing to be taught. And that is why accreditation by CGME is vital, and why we are doing what we're doing. And it also explains why it takes so long to build a new GME program, and why it costs so much, and why some areas aren't actually feasible for having residency programs, and then some are. Following a residency, a physician might choose to go on to a fellowship, and that's something that Healthy Rural California would consider down the road as we expand and develop our initial programs, but then look to expanding in the future if that's something that the community would like to see. Then you go on to practice of medicine, and that's actually serving patients without any faculty oversight and education. But I also like to add that CME is also part of that journey, because it's also what we do with Butte-Glenn Medical Society. When I talk about the flow of medical education as well, and I talk about medical schools, I wanted to show this diagram because when you think about medical education, the flow can stop after residency and fellowship. So typically when you go to medical school, you have residents and fellows, and they become patient caregivers, providers. That's it, right? They might get their CME, but they're not going back to medical school. And yet medical students are constantly learning the latest and greatest, new research, new understandings that have come from that research. And without having graduate medical education or a medical school in your area, you don't have the circle of information. You don't have mid to advanced career physicians gaining the insight that medical students and residents would be gaining. I know addiction medicine is one example. It was formed as a new specialty in 2015. Medical students now coming out of their residency programs are trained on addiction medicine. They're particularly in a primary care residency program, such as family medicine or internal medicine. Those are now standard, but if you have a mid or advanced career physician, they may be reluctant to learn about addiction medicine because it's just not in their wheelhouse and it's not what they learned in medical school. So I think that having graduate medical education in our communities helps tie us back into what medical students learn in the here and the now, and then keep that cycle of information and education flowing. I just wanted to share that as a way of describing why we do what we do at Healthy Rural California. So the other misconceptions about residency programs is that there was a long history, a tradition of graduate medical education and community health. So typically you would have a medical school near a hospital and or a large health system. And those elements would provide the resources, the trained staff, the faculty to teach and educate residents. That kind of circle that I just showed you, medical school nearby, it kind of gets all tied together. And then the community in which that medical school, hospital, or large health system are situated, they benefit by having this new education and new resources, new recruits coming into the medical field. Where there is medical education, there is active and ongoing efforts to address access to care and health equity. The simple fact is that residents, about 50% or more, tend to stay in the area where they do their residency. And that is why Healthy Rural California has embarked on graduate medical education first and foremost. So I'm going to state the obvious. There is no medical school, UME, between Sacramento and the Oregon border. In fact, it's larger than that. You'd have to go from the Oregon border into the middle of Oregon in order to find the next medical school. So it's a vast region without UME. There are only 2 family medicine residency programs in this vast area up between Sacramento and the Oregon border. And they're relatively new. The one that's in Redding, it's about an hour-and-a-half north of Chico, which is where we are planning to establish our residency programs. We have a fantastic connection with them. Dr. Debbie Lupeka is part of our GME committee and has been so incredibly helpful in guiding us all in a great direction. In fact, we hope to work with her and her residents in family medicine to meet with local legislators in the coming weeks to make sure that we are sharing the information that they will need to know to help us develop residency programs. So that's another product of what Healthy Rural California and Butte-Glenn Medical Society can contribute to these efforts. Butte-Glenn, surrounding counties, there's no large health systems. We are sort of an island within an island. No medical education, no large health systems. That's okay. This presentation is not to say that we should have large health systems. It's just, I'm observing and relating the fact that these 2 sort of drivers of change, agents of change, traditionally, are not present in the communities that we wish to see the change happen. So Healthy Rural California is stepping into that space, and we're very proud of that. In short, this area is GME naive, and I want to make sure that I share that term because it's well known in the ACGME world, but it may not be something in our own language at the local level. But what that just means is that there's no graduate medical education, no medical education. It's there's a lot to be learned in the region for graduate medical education. Meanwhile, ACGME has changed. So when you have an area with a lot of mid to advanced career physicians, such as what I see in Butte and Glenn counties, is that residency programs have changed. And the knowledge that a physician would have gained going through their residency program more than 10 years ago may not actually line up with what the reality is here today. So in recognition of areas needing residents such as ours, they have allowed for new models to bring GME to rural areas. So ACGME has recognized that they needed to shift and change in order to better accommodate and truly drive improvement in health equity and addressing access to care issues. They also understand that financial sustainability is parallel to a requirement in academic success. So ACGME is all about academic success. They want to make sure that every single resident gets a robust and quality education throughout their residency program at any of the clinical facilities that are part of the residency program. But in addition, just as much, they would like to know that there's financial sustainability, because the last thing they want to do is accredit a program, a new program, such as our psychiatry residency, only to find out that 3 years into it, we don't have enough funding to continue to pay the residents. And in a few slides, I have an overview of just sort of the general snapshot, big picture of the funding required to maintain our proposed residency programs. So ACGME needs to understand that we have an affiliation with a primary hospital, and all the clinical facilities are also sustainable, because the worst case scenario, which I was trying to describe, would be that in 3 years' time, the residency program has to shut down due to financial reasons. And then those residents are left 3 years into their 4-year program with nowhere to go and having to scramble and relocate their lives and their families' lives and change their whole academic journey because we wouldn't be financially sustainable. So making that point really loud and clear, because that would be terrible. Nobody should launch a medical school, medical education, without guaranteeing, confirming that the financial support is there for long-term. And we hope to have it forever. So GME is becoming also socio-culturally centered, meaning that they recognize that the GME programs are addressing health inequities and that rural areas have populations that suffer the most, and sometimes racial inequities, racial differences lead to other health inequities. So it's a complicated structure, and I hope to build a library of resources that can better describe this. But just know that part of the reason why we're doing what we're doing is to make sure that these health inequities in the area are addressed. Okay. So also I want to say that residents are not interns. Again, this is stating the obvious, but I think that there's sometimes a lack of understanding in GME naive areas that you can just bring a resident in and they can just hang out for a couple of weeks and provide care and go. They could, but there's a lot of ramifications for why that could be problematic in the long term. There's GME reimbursement caps. There's a whole science behind why that's not the case. But I also think it's a lack of understanding around the resources, the time, the staff that are needed, but also the fundamentally challenging task or requirement of having a graduate medical education program is ensuring that the residents have a positive, robust, and quality education. It just doesn't happen when you think of them as just interns. That's why building a medical school is a better analogy for what we're doing. In addition, the medical residents are practicing medicine and serving patients. So you wouldn't want to bring somebody in who's still, in the training process, the education world, and like leave them alone to care for patients because they haven't completed their education journey yet. So that's why thinking of them as interns is not a good way to go. Their education requires faculty who can devote about a half a day a week to support the residents. And this is also a heavy lift. We have worked with partners in the community who have said, we can't afford that. That's just no time in the day. They must be seeing patients. That's it. That's all we can do. And we just don't have enough of the providers to be faculty for residents. It also takes at least $1 million low end and at least 4 to 5 years to establish a new residency program. Typically rural communities or smaller communities, especially those without medical schools and large health systems, don't have the resources, the strength in a way to commit to this long-term high cost program without, there's not necessarily a guarantee that you'll drive revenue through clinical reimbursements of those residents that can then offset the launch expenses. So it's complicated, it's hard, but it's also something that can be daunting for smaller and independent institutions. However, oh no, it's not a however. The last bullet point I want to say is that not all residents graduate. And so the amount of resources that are needed, the faculty support, really the goal is to ensure that the residents have the education that they need in order to fulfill the requirements by CGME to graduate and then also to become board certified. So yeah, not all of them do finish and complete the residency requirements. So our goal would to make sure that 100% of our residents can make it through the program and get all of the information that they need and education and training in order to be successful. So quick review, 2019. I'm sure many of you are sick of hearing me talk about it, but there are some of you who are new to this, and I just want to make sure that we all understand how we got down this path and why. 2019, in the wake of the Camp Fire, the Butte-Glenn Medical Society developed a residency task force. We had estimated that 40 to 60 physicians left the area because of that fire. And that was just one of 6 disasters in 5 years. So we knew that there was a problem in access to care and that the circumstances of the last few years just made it worse. So the residency task force identified psychiatry as the top priority, with a primary care specialty next in line. At the same time, Butte-Glenn Medical Society, with me as executive director, also chose to set up Healthy Rural California as a separate but affiliated nonprofit 501c3. At the time, it wasn't linked to graduate medical education. But as we can see here in 2020, through a feasibility study, Healthy Rural California was identified as the lead organization for a consortium model. And there was no turning back after that. Shortly after the feasibility study in July of 2020, we applied for and were awarded a $1.8 million award. It was previously known as OSHPD, but is now HCI. And that's to the county and the behavioral health department specifically, because Healthy Rural California wasn't ready to submit that application at the time. We had not gotten all of the community buy-in that we needed in 2020 to proceed with Healthy Rural California as the sponsoring institution or to go down that path. So many, many thanks to our partners at Butte County Behavioral Health for stepping up. We were awarded $1.8 million, but we can't draw down those funds until we are accredited for psychiatry. And we hope to receive that accreditation by early 2023. And just as an update, we've also asked, the county has asked HCI for an extension due to COVID-19, and the effect of the pandemic really did slow down our efforts in 2020 in particular, and then the first half of 2021. So we did progress, we did move forward. We're excited to say that all of this despite the pandemic. And we also realized that we needed to reach 1.1 million to reach accreditation to draw down the $1.8 million award. 2020 continued. We were looking at the CMS GME reimbursement model of funding through a partnership with Enloe Medical Center in Chico. And we were just trying to identify all of the clinical partners at that time. We had a clear decision to not pursue a rural training program with a school of medicine. All of this to keep both funding and control of the program. That sustainability piece that I talked about earlier is so essential. And we felt that a rural training program wouldn't have the impact of bringing 28 physicians to the area, which is what I will be showcasing in a minute. But also that it would depend greatly on the medical school that may not have a vested long-term interest in our area. And that's not to say anything about any one of the medical schools that we were talking to. It is simply a fact that a consortium model that is located in Chico, Northern Butte County, and run in that community is going to keep us sort of within our own local control. We also at that time, at the end of 2020, were looking at raising money from our clinical partners. And I will show in 2021 that that plan did not work, but we had another plan in place that has been successful. So in 2021, we formed our GME committee, and a huge thank you to everyone who joined the committee. It's been wonderful to work with them. We were pretty quickly able to pull together our policies and then submit to CGME to be a sponsoring institution. That's the first accreditation that's needed in order to then get to the specialty accreditations. Our DIO, or designated institutional official, is Dr. Ted Zwerdling. He works with us for about 0.2 FTE. He's largely working through Adventist Health in Clear Lake with palliative care. He's a pediatrician by training. He is a wonderful leader for the organization and has been very flexible with our many different schedules, especially these last few months. So also a huge thank you to Butte County Behavioral Health for fronting some of the funds before we can draw down the HCI award. That's also been very helpful so that we can have the staff doing what needs to be done in order to submit the application. We were awarded a $500,000, or just under $500,000, a grant by HRSA. That's specifically for the psychiatry residency program. And we have applied to HRSA for the family medicine planning grant as well. But we haven't heard about that yet. Statewide recognition of our innovative psychiatry program also was just wonderful to see throughout 2021. We had a variety of different groups that understood what we were doing, the importance of it, the heavy lift of it, and that helped, keep us going as well. So this year, we hired Dr. Rachel Mitchell as our program director for psychiatry. She's been amazing. She started in early January. And as it turns out, she was a recent psychiatry and family medicine resident, got board certified in 2021. But she's been able to draw on her experiences and introduce us to some new clinical partners that have been incredible. So we're indebted to Dr. Mitchell and her leadership, and we're just lucky to have her on board. Our program coordinator for psychiatry is Lena Benton, also an amazing addition to the team and really keeping us going now. We have so many balls in the air that we're juggling. In fact, somebody just said that launching a residency program is a lot like playing pool in an earthquake, and I could not agree more. So Lena really keeps us on our game. We have also taken a shift in funding model to teaching health center funds. That is in large part, as I'll explain in a minute, a relationship with the VA of Northern California, and also just recognizing that it gives us more control as well with Healthy Rural California to maintain and sustain this residency program. We are nearing completion of our psychiatry residency application to CGME. It's got to be done in order to meet that HCI award that I mentioned earlier. And I do hope to take those first real steps toward establishing the family medicine residency as well. So this is a 10-year projection of the impact of graduate medical education through Healthy Rural California on Butte County and our region. I do want to say that we keep a regional approach, which is helpful in a lot of ways, because when you're talking about graduate medical education, you're not always going to be in one county. especially in rural communities where county lines, keep sort of resources in one area, as opposed to, well, maybe they could drive over the county line to Glenn County in, the community of Willows, for example. But they might need, one day a week, a resident to be there, right? But so we keep a regional focus being centered in Butte County. So with that top line, what you're seeing is the Community Psychiatry Residency Program, our first cohort arriving in 2024. So that's 4 residents. When you build out 4 residents in each cohort for 4 years, you get to 16 in 2027. And then it maintains at 16 residents going forward. And family medicine is a 4 by 3, which means 4 residents for 3 years. So you'll see in 2027, we also reach our full steady state at 12 residents. And in total, that's 28 residents per year going forward as soon as 2027. That's pretty amazing. And the impact of the Teaching Health Center funds means that at full steady state, it's almost $4.5 million every year. Largely, I do see at the note at the bottom there, I do want to point that out, is that the majority of those expenses are the residents' salaries, benefits, stipends. Again, it's not an internship, it is a paid clinical education opportunity, and it requires, a good deal of money. Plus, you must have a program coordinator and coordinator pay. I do want to note that when we look at our projections and the amount of funding that we would get through the Teaching Health Center model, that 2024, 2025, possibly into 2026, we're not at full steady state, so we're not able to draw down as the total amount of funding that might be needed to cover all of the expenses in those launch years. But by 2027, with 28 residents, and then sort of a shared office space and some of those shared expenses that can go into it, we should be self-sustaining by that time. So what is the Community Psychiatry Residency? What are we looking at? It's a 4x4 program, which means that there are 4 psychiatry residents in each cohort for 4 years. And as I just showed, we have a total of 16 that will be circulating through our region once we've achieved full steady state. They are required in the program to have 4 years of education. There's no shortcuts, there's no graduating early. It is 4 years of a curriculum that must be delivered. And Healthy California is required to be that support. That's CGME accreditation relies on that. We are looking at trauma-informed care and also health equity, and hopefully some population care, specifically working with different populations in the area. So of those 4 years, we are looking at the first year largely being in the Sacramento area at the VA and UC Davis. There are some key aspects of the curriculum that are not able to be met at this time in Butte County. And we're really excited about the VA in particular because they are already set up to have residents. Residents have their own office space. They even have staff support every single day to help them. They can fulfill all of their obligations to the first year of the curriculum, largely with the VA, and then a few smaller, like month or 2 rotations would need to be over at UC Davis, which is also in Sacramento, UC Davis Health. The VA also has education in its mission, which is a fantastic thing. When you talk about a GME naive area, the amount of work required to teach the facilities what they need to be doing, the faculty, to switch into here's 4 residents and you're responsible for their first year of the curriculum. That's a whole other lift. And the VA is already set up for psychiatry residents to step in. And it's in their mission, and it's going to be a great experience. And we also think from an education viewpoint, to be part of a larger health system, to see their integrated behavioral health, to live that for a year before coming into the community of Butte County, Yuba City area, will give them a framework of and a background so that they can be within this community without an integrated large health system or large hospital, but learn that in their first year, and then really drill down on what skills are needed best to serve a rural underserved community. Year two through 4 is still being determined, but we do know that child and adolescent psychiatry is only available outpatient in Yuba City, which is just below the Butte County line. And so we've formed a really great partnership. We haven't finalized the details yet, but there is no child and adolescent psychiatry outpatient facility in Butte County. So we're really happy to have the connection in Yuba City. We just met with the San Mateo Public Psychiatry for Social Justice in San Mateo. And we were very inspired by them. They actually have a 3-year longitudinal outpatient clinical experience for their residents. And they've been operating since the 1960s. And they have an over 90% retention rate, so that the residents who come into their program are seeking a public psychiatry residency and then find placement in that area following the residency. I could only hope that with Healthy Rural California's community psychiatry residency, that we will have that high of a retention rate. But even if we only had 25% retention, that would mean 1 resident, 1 psychiatrist choosing to stay in our area every year, and that would also be a huge game changer. But we hope to follow the San Mateo success story, and they gave us some really great tips on how to recruit and in order to retain the psychiatrists in the area. We are also very happy to have some positive discussions with both Stanford and UC Davis around didactics. And I can't wait to share the final full curriculum with everyone, probably sometime in early August. We should be able to say, yes, we have all of our agreements in place, and this is exactly how the curriculum is going to work, all of the block rotation schedules and everything. We should be able to share that in August. Now, the family medicine residency curriculum, hold on, did I miss something? Oh, no, okay. Is again a 4x3. We did apply for the HRSA planning grant, and that grant required us to have a critical access hospital in the application. And Glenn Medical Center was selected, and they were eager to partner with us. They also have great needs for recruiting family medicine doctors, so we think it's a fantastic partnership. We may not hear about that award until August of this year, which just seems like a very long time. But I'm also hoping to raise some funds in order to do the feasibility study and really pinpoint, what those exact needs are and what the resources can make available for us. I also want to hire a program director for this residency straight away, and that requires funding to pay them for their time. This program director will be essential to creating a very strong curriculum that will then be submitted in the application. I'm not going to say that psychiatry applications are easier than family medicine, that they are new, especially a community psychiatry consortium model located in a rural and underserved community. We're sort of unique for psychiatry. We've also gained a lot of attention, and there's also a national movement starting now, starting in 2021 and 2022, realizing that psychiatry has been sort of neglected in these vast GME efforts. But on the other end of that spectrum is family medicine. It has become a very competitive field. And so our application for family medicine really needs a strong program director who's gonna hit a home run for us in order to make that application as strong as it possibly can be. We're gonna need more office space for the second residency program for sure. And then I just wanted to note that we plan to have an integrated behavioral health emphasis, which I think will make us innovative, but also just completely necessary for the community that has suffered through 6 disasters in 5 years, which I mentioned earlier, but I'll say it again. So what's to be TBD, to be decided? Couple of things. Where will the reimbursements for care provided by the residents go? How will the residents be employed? At this point in time, it looks like we'll just have to create a separate physician-led corporation per California law. That's probably the best way for us to go. But we're meeting with lawyers and consultants to make sure that that's the most viable path. We also have to look at housing for the residents. Housing is extremely important. If you're gonna come to an area for 4 years or even 3 years with family medicine, having a good partnership with short and long-term housing partnerships, probably with real estate agents. All of that needs to be really hammered out in the next few months. And we're gonna need larger office space. I think I mentioned that already, but that's my segue into the next big initiative, which is our Health and Technology Education Center. Really excited about it. It is something that was actually started in 2019 as well and got put on the back burner because of the pandemic. But in 2019, I held a summit with Butte-Glenn Medical Society and sponsorship from North Valley Community Foundation to what we were really looking at was how do we rebuild the infrastructure of healthcare after the Camp Fire. That, we lost one hospital that was in Paradise. We lost a good 400 plus healthcare workers who lived in Paradise. We lost the 40 to 60 physicians that I've mentioned. So it was a massive impact on healthcare delivery in the area. Not to even, I forgot to mention this, but I will now, is that 10,000 people roughly resettled in Chico and other areas, which then impacted the existing and surviving healthcare infrastructure. So it was just this massive impact. And so I held a summit to really bring together a bunch of different thought leaders on how will we rebuild the healthcare infrastructure. And what came from that was workforce education and training. Tied into this was the graduate medical education work, the Butte-Glenn Medical Society Residency Task Force. At that time, because we did not have a crystal ball to know that just in a few months after September 2019, we would be in this pandemic and everybody would be converting to telehealth, whether they liked it or not. So at the summit, we did a lot of discussion around how telehealth could help delivery of care in the region that was so underserved and sort of compensate for the loss of so much of the healthcare infrastructure in the area. So somebody came up to me after that summit and said, there's money for a building or revamping an existing building. And I thought, well, fantastic. So what would that building need to be? And it clearly became about workforce education, but not just for medicine. It's for a bunch of other learning. But I started with medicine because that still is the area that I'm in. But then it became interprofessional learning, flexible learning space, and auditorium. But no one builds auditoriums anymore because that means that there's fixed seats with one presentation area. And yet so much of education, CME, there's so many more interactive, flexible spaces that are needed. So this is something that I learned when I worked at UC Davis, that flexible learning spaces can be the auditorium of the past, but yet be a much better use of bricks and mortar space. And so, of course, I'm going to start off by talking about graduate medical education and our 28 residents who are going to need a hub or a home. But I also think maybe telepsychiatry as a clinical space might be a good use of this new proposed building. We did do a feasibility study thanks to the Chico State Economic Planning and Development team. They did a fantastic job, and they showed that about $5 million a year would be drawn to Chico if we had this center built. And so then I really started thinking about how, when you talk about the healthcare workforce, it's usually a bachelor's degree and beyond. And so that really got me thinking about allied health. And then we formed a partnership with the Rural Simulation Center of Northern California, where they need about 10,000 square foot space to elevate their existing curriculum. Running simulation centers, very expensive. You have to have the most high-tech capabilities possible. Anyway, they exist already in Chico and they need a new space. And our partnership with them has been really wonderful. And we thought, what a great way to bring together interprofessional learning. Physicians do use the Rural Sim Center to update them, their intubation skills, although the pandemic did that for a lot of folks, unfortunately. But it's a great way to kind of look at what the needs are in the community to ensure that the workforce is educated in the community and then hopefully will stay in the community. So here's just a quick snapshot of the thinking beyond the bachelor's degree. So I note this because what I've observed in the community is a really great pipeline education and awareness building from middle school to high school to community college. And that is fantastic. So because I come from the graduate medical education world and I would love to see a medical school, I'm looking at the bachelor degree and beyond. So all of that is tied into the pipeline. I'm just saying that I think an emphasis on bachelor's and above degree programs would be what the area needs. And so, of course, with the Rural Simulation Center, we have a partnership with nursing. They need to expand their programs. So how can this new building provide that space? There's graduate medical education, of course. Clinical sites for psychiatry nurses, PAs, NPs. I mean, there's a lot more in that arena as well. And then the master's degrees, social work, LMFT, psychology. What more could we be doing? And of course, why not a regional small medical school? Medical schools, believe it or not, are needing to expand and be innovative. Medical schools are such an essential part of the physician pipeline, and they're feeling that pinch as well. And so as graduate medical education has expanded to provide that last bit of the journey for medical students' education, medical schools are also needing to expand. They're needing to diversify. They're needing to pull from a more diverse population as well. So why not a medical school? I wanted to wrap up with a quick note about funding. The Build Back Better Act offers great sustainability and support for graduate medical education efforts, especially in rural and underserved areas such as ours. So I am so proud to have been doing this work for a couple of years so that we are poised right here, right now, to take advantage of any funding that comes down from the federal government, as well as the potential state funding that is being discussed right here in our backyard of California. California is a big backyard. So a huge thank you to North Valley Community Foundation and to Butte County Behavioral Health. You've stood by our side since 2019. You've understood the impact. We haven't necessarily talked about the sociocultural impacts of GME, but I think it's understood. We just know that these residents are needed, and the funding that's required to make sure that we're establishing a strong, functional, and quality education program for our residents. I can't thank you enough for standing by our side through all of this. And then, of course, the state has the CalMed Force funding that would be available for family medicine. So that's what I wanted to share as of April 2022. We've come such a long way, especially since January, with hiring Dr. Mitchell and Lena and our clinical partners who have continued to find ways to really solidify this partnership so that we can submit our application to CGME, knowing that we've put our best foot forward and really made this program as strong as it possibly can be. And thank you to everybody in the community for your support as well. I hope you have a good rest of your day.